Hello friends, now today we will continue our previous lecture where we have started the anatomy of renal system. In that we have now discussed about 3 points. One is the position of the ureter. Normally we know that from kidney it exit through the hilus of the kidney where there is the relation of 3 VAP. Hilus of the kidney has a relation of 3, that is vein, artery and pelvis. Pelvis of the ureter, it goes down, then it comes into the pelvic cavity. Into the pelvic cavity it goes along the relation of 2 things. One is, in case of female, there is the uterosacral ligament. Uterine ligaments are there, and mainly the uterine vessels, they goes along the uterine vessels, and in case of male, vast differences. So what it is necessary that when there is any gynecological operation into the pelvic cavity, and when we have to ligate the arteries, mainly the ovarian or uterine arteries, then at that time there might be the chance of ligation of the ureter as well, which leads to blockage of the ureter, and at that site unilateral hydronephrosis will occur. Or there may be a damage to that ureter which causes leakage of the urine through that part. So there might be a question related to that any gynecological procedure, and there may be either blockage or leakage of urine due to the damage of the ureter as it enters close proximity to the uterine and ovarian vessels. That is one point. Okay. Now there is another point that we want to discuss, and that is about there is a ligament connection between the urinary bladder and the umbilicus. Okay, so when there is the urinary bladder and umbilicus, and there is a connection that is known as the allantois. Okay, that is known as the allantois. So this is the urinary bladder. Okay, and here is the umbilicus. This is umbilicus, this is urinary bladder. There is a connection known as the allantois, A-L-L-A-N-T-O-I-S, allantois. This allantois is usually after birth, it gets remnant and it gets disappear, and remnant as and that is median, M-E-D-I-A-N, median umbilical ligament. So what is more focused about is that there is a connection between the urinary bladder and the umbilicus. There is a connection between urinary bladder and the umbilicus, urachus we call it. If it is allantois or urachus, if it is remain, it usually after birth get disappear and remain as median umbilical ligament. There are other medial umbilical ligament. Don't get confused with medial umbilical ligament. They are remnant of that umbilical arteries, of the umbilical arteries, not that is of this allantois. Okay, so if allantois, this is allantois and this median, and that is umbilical arteries for medial, M-E-D-I-A-L, medial, M-E-D-I-A-L, that is medial umbilical ligament. That is median, but this is median. So median umbilical ligament is remnant of allantois. That is the connection of the urinary bladder and the umbilicus. Okay, but if it remains persistent even after birth, then what happens? The urine from the bladder will leak out to the umbilicus when the baby will cry, play, when will be the prone position. In this situation, the urine will leak out from the umbilicus, and there will be a repeat urinary tract infection. That is important. So there might be a question related to that a baby has repeated urinary tract infection, or you have examined the urine, there is found of the urine infection. So there might be a question related to this. Okay, or there may be other situation like that if it remains pattern only after this, proximal to the urinary bladder, then there will be a formation of diverticulum. If this is also not persistent, but only middle portion is persistent, then it will remain as the urachal cyst. If it is, this has been obliterated, but only this portion has been not obliterated, then it will remain as the sinus, umbilical sinus, and there will be the persistent infection, repeated infection in the umbilicus, and patient and baby may be present as umbilical tenderness with umbilical discharge. So this structure is also one of the important, and question may be related to that as well. Okay, now there is the another point we need to discuss about the congenital ingulan hernia. Normally, when after birth, the kidney goes up, that you send up, and the testis goes down into the scrotum. That is the main normal process. When testis goes down into the scrotum, through that is the peritoneal layer also goes up with it. That is the processus vaginalis, which ultimately remain as the tunica vaginalis. The layer, if you know the layer of the scrotum, then it comes to the testis, then there is a layer called tunica vaginalis, which is a remnant of the peritoneum that descent, that goes well descent, and it usually get disconnected or obliterated. But if anyhow that this is the peritoneum, and if it is the testis, usually testis has this tunica vaginalis, and if it remains persistent, that is intact, it doesn't get detached, then there will be a formation. If there is a small opening, then only fluid will leak out and formation of the hydrocele. But if there is a large opening, then there will be a intestinal content will come and form inguinal hernia. That is important. That is congenital inguinal hernia. Okay, so I'll repeat it again. If there is a persistent of processus vaginalis, then there will be, if the opening is small, then the fluid will leak out and will lead to the hydrocele. Hydrocele can be diagnosed with the transillumination test with the torchlight or by ultrasonography. Okay, or there may, if the opening is large, then intestinal content will come up, down and form inguinal hernia. So that is also a congenital abnormality that is related to this. Okay, so we have discussed that also. Now let me discuss over here, that is the, actually if you go to the function of the kidney, there are a lot of function of the kidney. The main important thing is that when you eat anything, that get absorbed into the blood, and from blood it goes to from the portal vein to the liver, to the heart from the brain, again to the right heart to left heart, right heart to the lungs to the left heart to the whole body. Okay, and about cardiac output, 22% reach to the kidney. Okay, in 22%, that those who has reached the kidney, from that, except if we have talked about I have talked about this is the basement membrane, then this is the capillary endothelium. Okay, then there is another component is epithelium of the porocyte. Okay, so what happens? This is the glomerular filtration barrier. This is the barrier composition of the capillary endothelium. Then the basement membrane. This is type 4 collagen with heparan sulfate is there, and there will be the outside is the porocyte layer. Okay, epithelium layer. Now the substance that is accept the plasma protein. They are negatively charged, so they express the plasma protein. Accept the plasma protein and the cellular component of the blood. Everything from the blood pours into this Bowman's capsule and finally goes to the tubule. So whatever you have taken, whatever you have ate, and everything goes into the tubules. Now the main function of the kidney is to reabsorb all this structure, all the component. That may be glucose, that may be vitamins, that may be nutrients, minerals, sodium, everything gets reabsorbed. Okay, this is main function of the kidney. So if you say one main function, this is reabsorption of the, not absorption occur in the intestine. This is reabsorption from the kidney tubule. So reabsorption of the useful substances that is required for our body. Okay, next is excretion of the harmful substances that doesn't require will be excreted. Okay, formation of the urine, then maintenance of the water balance, maintenance of the electrolyte balance, maintenance of the acid-base balance. These all are the function. There are excretion of the high toxic compound, metallic compound that are being excreted through kidney. There are a lot of endocrine function is there. It helps in produce erythropoietin, which helps in the erythropoiesis. It help in the formation of vitamin D. Okay, then it releases the renin, which maintains the blood pressure. That are the lot of function. Okay, so when we have discussed in brief about the function of the kidney as well, but further, if we goes and we study the structure of the nephron, kidney nephrons are usually divided into two parts. That is the renal corpuscle and renal tubules. Okay, so renal corpuscle and renal tubules. So renal corpuscle includes glomerulus and Bowman capsule, where tubules include PCT, proximal convoluted tubule, there is a loop of Henle, distal convoluted tubule, collecting ducts and all that. That is the part of tubules. Okay. So when we see here, what happens? The afferent, through afferent, the blood comes. It goes into the glomerular capillaries. There is two set of capillary. This is high pressure bed and this is the peritubular capillaries, which is the low pressure bed. Okay. In high pressure bed, there is the filtration occur. Then how does it filtration occur? Filtration is normally anything in our blood is withhold. Normally water is withhold within the blood by two forces. There are four forces that applied every time into to the liquid component into the blood. Okay, there is this inside the blood. There is hydrostatic pressure. This is the of glomerular capillaries. That is pressure of the glomerular capillaries, and there is the plasma protein which exerts the osmotic pressure, oncotic pressure. This oncotic pressure tries to hold the water, whereas this hydrostatic pressure wants to pull out the water. Okay, so pull out, this goes out. This hydrostatic pressure goes out, but whereas this osmotic colloidal pressure want to keep in. Then there is same force applied outside also. In the Bowman's capsule also there is hydrostatic pressure and oncotic pressure. Okay, so hydrostatic pressure of the Bowman's capsule is trying to push the fluid within what is the main purpose of any hydrostatic pressure is to put outside. So this is outward force. Okay, so this want to put outwards. That is important. Where outward means outwards from here Bowman's capsule is into the capillaries. That you have to understand. It doesn't mean that pulling out from the blood capillaries. It is exerting pressure oppositely. It is whatever water is present into the Bowman's capsule, it wants to push into the capillaries. This is hydrostatic pressure, what it means. And this is the osmotic pressure due to the plasma protein of the Bowman capsule. Since there is almost very few protein is present in the Bowman capsule, we consider it as a 0. Okay, so we consider it as 0. This hydrostatic pressure inside the glomerular capillaries is 60. Then minus. There is two force, that is hydrostatic pressure inside that is going to pull out. Okay, and this osmotic colloidal pressure of the Bowman's capsule, that also tries to, this wherever is the protein, they tries to pull the water towards itself. Okay, so this pulls outside, so they have pulled. Now opposite force, inward force, is the plasma protein that is present in the blood. Whatever plasma protein main property is to pull the water towards itself, so it is pulling it inside the capillaries only. And there is hydrostatic pressure in the Bowman's capsule, that also pulling out. That this is 32, 80 plus 32. So it is equal to 60 minus 50 is equal to 10. So there is 10 net force, that through which the water, all the solute components are filtered from the glomerular capillaries into the Bowman capsule. The net pressure is 10. That you have to remember. There will never you will give the calculation, but you have to understand what are the pulling force and what are the pushing force. You have to also remember that this colloidal osmotic pressure is due to plasma protein. If due to any reason, if the plasma protein goes down, if it is goes down, suppose either hydrostatic pressure goes up, then also this will increase, either this plasma protein, this glomerular capillary plasma protein goes down, then also this increase, which means that if the plasma protein is decreased in nephrotic syndrome or cirrhosis of liver, then what happens, this net filtration pressure will also increase, okay, and it will applies in your blood vessels in the periphery as well, where interstitial fluid, Bowman's capsule will replace with the interstitial surrounding interstitial fluid which is present there. There also what happens, since pressure either increase or osmotic pressure decrease, the fluid will leak out and cause edema. That is the point. Okay. So where this hydrostatic pressure will be increased in heart failure, there will be the pressure inside into the capillaries, and that will leads to the increased capillaries will be leak out the protein. So there will be the transitory fluid leakage in the heart failure. Okay, edema. In case of where there will be the decreased protein content will decrease in the nephrotic syndrome, there will be protein loss, liver cirrhosis, there is no protein production. Due to that, osmotic pressure goes down, net filtration pressure has come up, so from blood water leaks out and causes edema. That applies there also. So I am just correlating. Okay, let's forget that. Now when you come here, there is the afferent arterioles, afferent and efferent, each comes and E for exit. Okay. Then we have discussed about this distal convoluted tubule, macula densa, extrapulmonary apparatus. This is the extrapulmonary cell is Bladder receptor, and macula densa is Chemo Receptor. You have also understood about that. This is if the blood pressure goes down, then the extrapulmonary cell is activated and secrete renin. If sodium content in the distal convoluted goes down, then also this is the chemoreceptor, it sends the sodium load. If it is less, then also it stimulates the extracellular cell and produce the renin and activate the renin angiotensin mechanism. This too is there. Now we have to understand one more thing, that if afferent and efferent, what are these two factors? Main important is what you have understand. You have understand the net filtration pressure. Now filtration fraction. Actually, filtration fraction is GFR by renal plasma flow. Before understanding this, you have to understand the renal clearance. Okay. So let me tell you what is renal clearance. Renal clearance is the renal clearance. The renal clearance of any substance. Renal clearance of any substance. You take anything like inulin, glucose, para-aminobutyric acid, or anything. Okay. So renal clearance of substance, how can it be defined? It is defined as the urine concentration of the same substance into urine flow rate by plasma concentration of the same substance. Means that if what is the renal clearance? If you said that, means it is the volume, virtual volume of the plasma that has been cleared. This much amount of solute of that substance concentration has been cleared from the plasma. It means that. Okay. So renal clearance equal to concentration of that substance into the urine by this is urine flow rate per minute by same substance concentration in the plasma is plasma clearance. I'll give you one example. Suppose inulin. Inulin is neither secreted neither reabsorbed. So what happens? Its concentration is here in the urine flow rate is there, and this concentration is the plasma in there. So it will come as actually 120 around 120 ml. Okay, per minute. So it indicates that if inulin is neither reabsorbed nor secreted, and if you calculate the renal clearance of the inulin, then it will come as around 120 to 125 ml per minute, which is equal to GFR. For calculation of the GFR, we usually use inulin clearance because inulin is neither reabsorbed nor excreted, so it will give the exact value of GFR. Okay, so if you want to know the GFR, we will know the inulin clearance. Okay, if we want to know the renal plasma flow, then we will check the para-aminobutyric acid clearance. So para-aminobutyric clearance will come as around 600, right? Which is renal plasma flow. Okay, so GFR by renal plasma flow 120 by 600 is equal to 20%. Is 20%. Normally, what we do before GFR, we use urinary clearance, but in a clinical practice, we usually use correlate with creatinine clearance. Creatinine clearance and GFR or urinary clearance value is almost same, although exact is urinary clearance, because creatinine clearance overestimate the GFR that is there. It is slightly excreted into the renal tubules, so there is problem of that. But GFR, if we use in the practical guideline, in the clinical practice, we use creatinine clearance. Okay, for renal plasma flow, we use para-amino hepatic acid. So filtration fraction is 20%. That you have understood. Okay, so you have understood that. Now, if we can calculate this, you have understood about GFR, you have understood about the renal clearance, you have understood about the renal plasma flow, how to calculate. If we want to calculate renal blood flow, then it is renal plasma flow by 1 minus hematocrit. Correct. Okay. Now we have understood this also. Now there is filtration fraction. We have understood about filtration fraction. Filtration load is nothing. Filtration load is GFR into plasma load, plasma concentration. So what happened? This is the actually filtration load is excretion. Okay. Now there is reabsorption as well. This GFR into plasma excretion. This is now excretion. This is filtration load. Then excretion rate is urine concentration into in volume. This is urine concentration into volume urine per ml. Rate of urine per minute. How much ml of urine is flowing per minute. This is rate of urine flow, and this is urine concentration. This is excretion rate. Now, if we want to know any substance is either reabsorbed or excreted, that can be known from here. If this is filtration minus excretion. If suppose filtration load is 80 and excretion is only 60, so 20 has been reabsorbed. That you have to understand. If filtration is 80 but excretion you have found that 100, so 20, so there will be just opposite, then we have to subtract 100 minus 80, so 20. That means that 20 has been secreted into the urine. That is important. Okay, so we have understood that also. Now let me talk you about what are the factors that affect this afferent and efferent parameters. That is important. Normally you have to understand that GFR, renal plasma flow and filtration fraction. These three things get affected how? You have to understand these three things. That is also mentioned in the first aid. You can go through it. Okay. Number one is what happens if afferent arteriole get constricted. If there is a constriction, afferent constriction. So what will happen? Since this is constricted, no blood flow comes. Since no blood flow comes, the renal plasma flow is decreased. If renal plasma flow is decreased, GFR will be decreased. Filtration fraction is GFR by renal plasma flow. Since both has decreased, filtration fraction remain unchanged. Okay. If we constrict the efferent arteriole constriction, then what happens? Since it is constricted, there is increase in pressure over the hair, so GFR will be increased. But since here is constriction, no blood more flow will come, so renal plasma flow is decreased. Now renal plasma flow is decreasing, GFR increasing, so filtration fraction will be decreased. Okay, so now will be plasma protein concentration. If plasma protein concentration is increased, plasma protein concentration if come more, then what happens? That renal plasma flow doesn't get affected because it is a component of this plasma, so there is no problem. But GFR will be decreased as there is, in comparison to water, there is more protein, so water is less. Water component has been less come out, so GFR is less. Now since GSR has decreased, renal plasma flow no change, filtration fraction will decrease. Okay, if there is decrease in plasma protein concentration, if plasma protein concentration is decreased, now opposite will happen. Since there is plasma concentration is less, water component is more, doesn't affect anything to the renal plasma flow. Since water is more, plasma protein is less, more filtration occur, GFR will increase. GFR increase, filtration fraction is increased as there is no change in plasma flow. Okay, so there is also one thing, two more things we can discuss over here. That is dehydration and suppose ureteric constriction. Ureteric constriction, you have constricted the ureter. There is the backward pressure. Backward pressure means that this hydrostatic pressure of the Bowman capsule has increased. Since hydrostatic pressure is increased, this pressure is increased. Now this gap will be reduced, and since this has been reduced, net filtration pressure will be reduced. So GFR will be reduced. That is you have to understand. But this pressure doesn't affect in the renal plasma flow, so filtration fraction will also be decreased. Okay. Now last one is dehydration. Dehydration. In dehydration, there is less. Body will try to conserve the fluid, so less blood flow goes to the kidney. So kidney, there is less blood flow. Okay, but kidney will try to maintain the GFR. Although the GFR will be decreased, the renal plasma flow is more decreased. So GFR by renal plasma flow. If renal plasma is more decreased and GFR is only one time decreased, then there will be increase in filtration fraction. So that you have to understood, and this question, this scenario can be asked. The final thing is about glucose transport. Normally when you talk about the glucose transport, there will be 200 is milligram per dl is our threshold. When glucose clearance, okay, from here excretion will occur, up to this reabsorption will occur. Okay, what is, let me explain you a little bit. Okay, when we have our blood glucose level is 60 to 120 milligram per dl. Whenever the glucose level goes up beyond 200, then that reaches to the threshold. That reaches to the threshold means after that kidney is unable to reabsorb the glucose. That is main concept. So after 200, it will actually start to excrete through the kidney, and that is known as the glycosuria. There is renal glycosuria, alimentary glycosuria, and diabetes mellitus. Okay, in pregnancy there will be reduction of this threshold. Due to that, there may be a glycosuria. So renal glycosuria is due to any renal disease, the threshold has decreased, and normal blood sugar you have, but also you are having the glucose in the urine. This is renal glycosuria. Alimentary glycosuria is you had the food, and at the time of the peak of the hour, when blood glucose level very high, and when the blood goes to the kidney, then it finds that it is more than its threshold, then it gets excreted in the urine, and glucose is found in the urine, which is known as the alimentary glycosuria. In diabetes mellitus, if you have 300, 400 blood sugar, so if it is above the threshold, then also the glucose will appear in the urine, and it is known as this is pathological, and it is a clinical use of this glycosuria. Okay, and one time another is pregnancy, that will reduce this threshold, and in that case also it will reduce the threshold of glucose as well as albumin, so you will find glycosuria and menorrhea in pregnancy. This is normal physiology. Now there is one more thing that we have to understand is TM. That is TM. One is threshold and another is TM. TM is the max saturation of all the glucose transporter. There is sodium glucose co-transporter in the PCT. If all receptors are saturated, that point is called TM, which actually, if all saturation 375 milligram per dl of glucose is absorbed, if all receptors get activated, all get saturated, and this much amount of glucose is absorbed milligram per minute. Okay, so any glucose level above this will be excreted. After this, there will be at this point there will be like this. At this point there will be plateau. There will be this flat formation. Means only 375 milligram of glucose will absorb. If it is reached to 400, if it is to 800, whatever the glucose level in your plasma, it will absorb only 375 ml per minute. Above that will all be excreted into the urine that will be lost. So this is the concept of threshold and TM, that is saturation of all the receptor. Well, there might be a during splay, there might be a this portion, this rhizarian, and there is a splay. This is the maximum saturation of reabsorption. This splay is due to heterogeneous of the nephron, and because all the receptor has not been saturated, so there is a splay of this column. Okay, hope you have understood. Thank you.